of the organizing team of AOGD, Endoscopy Committee, Dr. Kanika, Dr. Induchuk, Dr. Swati Agarwal, it's my pleasure and privilege to welcome you all for yet another masterclass series. This time it's Robotics on Focus. This evening we are blessed with the presence of seniors like Dr. Achla Batra, Dr. Malvika Sabarwal, and Dr. Pradeep Chaube. They are the stalwarts of endoscopic surgeries. The icing on the cake is the panel discussion moderated by Dr. Induchuk and Dr. Kanika Jain, with galaxy of panelists like Dr. Vandana Soni, Dr. Dinesh Kansal, Dr. Rama Joshi, Dr. Vipin Tyagi, and Dr. Anupam Bahadur. They all will share their experience today evening. At Gangaram Hospital, we were blessed to have learned the basics of endoscopy from Sir Dr. Chaube way back in 1995 and 1996. I think, sir, you have taught almost everyone the basics of endoscopy and laparoscopy in Gangaram Hospital. And when we heard that you have finished more than 100 cases of robotic surgery, I thought we must listen from you. What made you switch or do laparoscopy together with robotics? And what was the reason behind it? We wanted to know from you. Robotics are the future. They complement and complete our basket of minimally invasive surgeries. And of course, it has a very short learning curve. Now I hand over the floor to Dr. Swati for the proceedings of the evening. She is young, energetic, enthusiastic, vibrant endoscopic surgeon. May I have a CV so that I can introduce her formally? She is a professor at Lady Hardinge Medical College. May I have the CV or Dr. Swati? Yeah, she's a professor, Department of Obs and Gynae, Lady Hardinge Medical College. She's been awarded Foxy Late Praveen Mehta Training Fellowship in Endoscopy, Foxy Dr. Kamini Rao Orator for North Zone, awarded Foxy Ethicon Traveling Fellowship, awarded Mrs. Kumud Baliga Medal for Best Senior Resident in LHMC, awarded gold medals in microbiology, ophthalmology, surgery in MBBS, university topper and gold medalist in final MBBS exam, awarded medals for paper presentation in AOGD conference, national mentor for Government of India Lakshya Initiative, more than 50 publications. We are waiting to hear from you, Dr. Swati. Over to you.
Thank you so much, ma'am, for that kind and elaborate introduction. It is indeed an honor for me to be hosting this webinar under the guidance of all of you. And we have none other than the star speaker of the day, Dr. Chaube. But before we begin, I would like to introduce our guests of honors for today, who have graciously consented to be with us. Our first guest of honor is Dr. Achla Batra. Is madam here? I think Dr. Ashwari is somewhere, but Madam is the President AOGD and is the guiding force behind whatever we do in the committee under the aegis of AOGD. But we do have here another very esteemed guest of honor, the one and only Padam Shri Dr. Malvika Sabarwal, the jewel of Delhi and another guiding light for all of us. She's the Chief Department of Gynae and Obs at Jeevan Mala Hospital and former chairperson Delhi State, founder chairperson of Delhi State IAGE. I think rest all, if I go on to read her CV, it will be the end of this webinar. So without further ado, I request Madam to just speak a few words for us.
Thank you so much for the kind introduction, Dr. Swati. That was excellent. And I am very happy for all of you who thought of organizing robotics in gynecology as a masterclass. And, we all are laparoscopic, gynecological, endoscopic surgeons, but we all must understand that where is the need when we have to cross the line and command the skills of robotics and how it's going to be, helping us in our practice, whether it is the patient's demand or whether it's a complexity of a surgery, which will definitely, the outcome will be much better if you use a robotic arm, which has got precision, it's got flexibility and also full control. So definitely the outcome is much better when you're using a robotic arm. We must know the deterrent factors like cost and the availability of this kind of a thing. So this, the robotic is not available. The console and all this setup is not available in all the hospitals. So we must know the constraints that are there, and we judicially have to understand as to where we stand and how much we can go. And as you said, none other than Dr. Pradeep Chaube, our Pradeep Bhai, who's going to be telling us all about how he started laparoscopic surgery up to his whole journey into robotics. And then the excellent panel discussion, which is going to be moderated by Indu and Kanika, with stalwarts like Vandana Soni. And I think all of you who are there, Mala Srivastava, who's already given a good introduction, Dinesh Kansal, who's doing a lot of robotic surgeries, Rama Joshi, Vipin Tyagi, and Anupama Bahadur. So we look forward to an excellent talk as well as discussion, which is going to help to decide as to how we have to progress next. I hand over to the next Swati.
Yeah, thank you so much, ma'am.
Thank you very much.
Thank you, ma'am, for your words of encouragement. It is my proud privilege to introduce the chairpersons of the next session. We have the ever graceful Professor Dr. Kanwal Gujral. Madam is the chairperson, Institute of Obstetrics and Gynaecology at Sir Gangaram Hospital, and in charge of the high-risk pregnancy clinic. And she is like one-stop person for all the queries in high-risk obstetrics. I welcome you, ma'am. Our next chairperson is Dr. Harsh Khullar. Madam is Vice Chairperson, Institute of Obstetrics and Gynaecology at Sir Gangaram Hospital. And she's the ex-Secretary AOGD. She was the Secretary AOGD 2008 to 9, ex-Joint Secretary IMS Delhi, ex-Secretary of NARCHI Delhi, Organizing Secretary of AICOG, has delivered many guest lectures and is a life member of many societies, and another very, very senior obstetrician that we all really revere. And our third chairperson is the young and dynamic Dr. Mamta Dagar. Ma'am is a senior consultant and professor at the Institute of Obstetrics and Gynaecology, Sir Gangaram Hospital, and very, very academically oriented, I must say. And all the postgraduates under her are really blessed to have a teacher like her. So I think I am the only one standing between Dr. Chaube's fantastic lecture that everybody is waiting. So without further ado, I hand over to the chairpersons to please introduce sir and carry on.
Thank you, Swati, for wonderful introductions for everybody. And my pleasure to introduce you, Dr. Chaube. So good to see you. And just a formal introduction. He is a chairman of the Institute of Laparoscopic, Endoscopic, Bariatric Surgery and Allied Surgical Specialties at Max Hospital. He has been decorated with Padma Shri by President of India, Doctor of Science, and he has been a president of so many societies, international and national, 7, 8, I can read them, and 200 original scientific papers, books, so much. That you know him well, but we at Gangaram know him as a pioneer in laparoscopy surgery, who taught, as Mala said, each one of the consultants sitting here doing laparoscopy work. He was the one. He was the first one to perform a laparoscopic cholecystectomy, and I remember those days how we watched him. And then he built the minimal access surgery department, took it to great heights, you know, operated on who is who at that particular time, and finally we moved on to Max. And as a person, he's such a nice human being, humble, helpful, you know, very gentle, no controversies, no egos. He is a thorough gentleman to the core as far as I know him as a person. With that, Dr. Chaube, we are waiting to hear your journey from laparoscopy, which you did with us, to robotic, which you're doing at Max. Welcome, Dr. Chaube.
Thank you. Thank you very much. It's really, really heartening and also quite emotional to be with all of you who have been part of this journey of almost 3 decades now, you know. And I'm sure you have seen us struggling with the laparoscopy and the types of resistances, active and passive, and
Absolutely.
also learning that new technology has been possible only because of friends like you and all other colleagues. I always feel that any success in life can only be with blessings and wishes. There are a lot of people will do hard work, but anybody who has got good wishes and possibly the blessings can probably flourish. And I'm always grateful for the good words spoken. And when Kanika called me, I think first opportunity I agreed that because this gives the platform to be interacting with all of you on a very interesting subject, though new to us, but we have a reasonably good experience by now. And today, I think we will be just sharing a couple of our slides. Can I share the slides now? Yeah. So as the topic given to me is the transition from laparoscopic to robotic surgery. And I recollect my next slide, which is my first slide when I started laparoscopic surgery. And you know the type of slides I would like to mention, that this slide took almost about 1 day, morning till evening, sitting in front of a computer in a small place in a computer shop. And he created this. This is my vision, which is almost 30 years back. And of course, you are 30 years younger at that time. And we were looking at the flowers of laparoscopic surgery, whereas we were doing the conventional surgery, and especially with Dr. Mahajan, they are doing the great open cholecystectomies and other general surgeries. It was a dream, and we were not very sure whether those flowers are flowers or not. And if you see that one step is on the white sort of or gray ground, and we were not very sure whether this ground is solid or it is just a snow which will possibly take us to a different location, which is unsafe. And this is my first slide, and I take great pride and I feel very nostalgic that this is a slide which I used to present when we moved, and everybody used to say that what is laparoscopy is coming. And I think over a period of time, we realized that we have seen in not too long back, but it's just in 1980s, we have seen something like this, which was the imagination, human imagination of a space station. And now we have got this space station, which is already there. And every now and then you hear that the ships are going to replenish the supplies in that and repair this space station. So it's within couple of decades, I think the whole world seems to have changed to what we used to imagine. No doubt we know that there has been 3 revolutions: asepsis, anesthesia, and laparoscopy. It is very difficult to say whether it was a revolution, because the revolutions are too dramatic. I think it was quite dramatic, but at the same time, really gave a total different aspect to the surgeries and the surgeons. Now, we would always like to give great respect, regards, and our gratitude to Coach Sam. I had the opportunity to be with him in the initial period, and also share sometimes the stage, because he was talking about the laparoscopic gynecology, and we were talking about the laparoscopic abdominal surgeries. And he's the person, I think, I still feel that the person who gave laparoscopy what it is today. And it was the starting point when he, and I'm sure you all know much more than what I know about him. And he did the appendectomy, and that time the points were raised how the gynecologists can do the appendectomy, endoscopic appendectomy. But this is what the life is like. Second person, we talk about Philippe Moret in 1987 from France, Paris, Bordeaux, France. And he did the first case of cholecystectomy. But let me also tell you that we just lost him a couple of years back. And again, we shared the stages and interactions many times. So he was a gynecologist, and I'm sure quite a few of you may not know that Philip More was a gynecologist, and very interestingly, he was operating a lady for her gynecological problems. And the lady says that I have got a gallbladder stone also. Why don't you just look how bad is it, so that I can decide on the surgery, conventional surgery for cholecystectomy, because that was the only option. And she went to Philip More for gynecological cause because it was a laparoscopic gynecological intervention. So, she was not really much worried about it. And what happened is that Philip More just turned his telescope towards the gallbladder just to give a feedback to the patient after the operation, that how was the gallbladder, whether she needs urgent surgery or she can wait. And while he was fiddling around with maybe some instrument, he realized that he could make out the cystic artery which was going to the gallbladder, and he could very clearly see that must be so-called lollipop gallbladder. And he just tried to see the anatomy type of, just out of curiosity, and suddenly he realized that he has got a cystic duct separated and cystic artery separated. And being an expert laparoscopic gynecologist, what he did was he just tied those two structures and removed the gallbladder. And once, like with a lot of enthusiasm, we removed the gallbladder, but then he realized the litigations problems and the medical legal issues which can arise by removing a gallbladder without a consent. But when he told the patient that you had this, and what will you do if I remove your gallbladder laparoscopically? And she says, we will celebrate, and then he told her that, okay, your gallbladder has been removed laparoscopically. So this is one first documented laparoscopic cholecystectomy. Thanks to all of you sitting here to, like I'm sure in a lighter moment, I think we can always talk that you give birth to the thing, but you gave birth to laparoscopy, as well as you gave birth to the laparoscopic surgeons who are all across the world. And then gallbladder became the gold standard, without any studies, without anything, because it had the drive of the patient, the kindness to the patient, and the pain which is less, the cosmetic outcomes which are there. So we know in 30 years now what he had. Historically, I just wanted to tell you that this is the first workshop. If you can see, this was in 1995 in Delhi, the first our Indian association, and Vidyachan Shukla, who was a parliament minister, inaugurated that. And the workshop, we showed the gallbladder stones, diseases, and laparoscopy. And this was the situation. You can look at the excitement. People were not willing to even sit on the chair. And this is Darbar Hall of Taj Palace. People were so curious. And this is the last session which was there. So it generated the curiosity. And I'm sure, at least I feel the same today of a robotic surgery, which we are going to discuss. So when we moved from the conventional surgery to laparoscopic surgery, unfortunately, we lost one dimension, because open surgery, we all know, is a 3-dimensional surgery. And then we moved to a 2-dimensional laparoscopy without any hesitation. But we had to learn quite a bit. We have to adopt to the 2D technology, because there was no depth perception which we were used to. So this was a quantum jump. Though we were moving from 3D to 2D, we did not hesitate, because it was good for the patient. It was good for the diseases. Gradually, after gallbladder, appendix, hernia, oncosurgeries, and everything for that matter. So, but we did that. And today, possibly, I shall say that we have to look that we have received and got back our 3rd dimension lost with the robotic surgery. So I would say that robotic surgery, if for any simple thing which you want to do, why should you do is because you want to get your 3D 3rd dimension back for the laparoscopic surgery. What could be, sone mein suhaga wali baat hai, It could be laparoscopy and it could be 3D. So this is what is our mind today. And I know that there will be a lot of question marks, as these question marks depict my question, my thinking on that. And these are the question marks which possibly over a period of time, as laparoscopy has proved, I'm sure with no time, this will there. The technology keeps on evolving. We all remember the mobile phones or the landline phones or those trunk calls which we used to make, or STD what we used to make. And today, look at it, the whole world is within a couple of seconds away from each other and is available. You can do a video conferencing, audio conferencing, and that conferencing what we are doing without coming to any place. So this is a two-dimensional Congress which we are doing, and I'm sure soon we will be into the moving from virtual also. And we all are aware of how the development has taken place. One single chip to 3-chip camera and HD cameras and digital cameras. Something came. This is a special mention. These are all waxing and waning. This is first thing which you see is the robotic arm which was put at the telemal telescope. You can see the telescope in the center. So it was put through umbilicus, and something like this spider which we used for a couple of months, and the company stopped. Then I'm sure we did the lapro lift, and we did the hand disc technology, but nothing worked because it did not have the drive and it was not the reality. But I think all of us, we were missing the third dimension in laparoscopic surgery. And the third dimension which we are missing now has been acquired, and this is the reason. So now you recollect my first picture where I showed the jump of a young boy into trying to fetch those roses. Now this is my juncture, and our team has got a next leap of faith. This is what, but this is, is a technological leap of faith. This is a bungee jumping equipment, and you see you are bunging with, you are jumping with all the equipments, technology which has been time proved. So this is, to me, looks the next leap of faith as compared to 30 years back, which was those faith, the jump. So this is what the difference in the images. Robotic surgery, especially after the artificial intelligence which has come in about 5-6 years back into robot, has really excited me, and I'm sure to you as well, as much as it has done to the world. So robotic systems were available, but I think adding the intelligence, artificial intelligence is there. And in 1999, you see the Da Vinci robot which was there. The first robot which you see, I went to Cincinnati in USA, and 12 of us, we were invited across the globe to certify this Da Vinci system. This is just 99, and we certified, our comments were taken. We did some exercises, complex exercises. This was in Cincinnati. And now you see, after so many years, we are talking about the robotic platform. Now, because there was no intelligence there, but now it has got the intelligence. And that time we were using it for more and more robotic oncology, as we all know. And the prostate is one single, like the gallbladder surgery gave gold standard to the robotic surgery. I think the carcinoma prostate gave a big push to the robotic surgery because of the presence of it in the pelvis. As you all are dealing the organs in the pelvis, while you're doing laparoscopy, your movements are very much restricted, because for abdominal surgeries, for us, we distend the abdomen, but you cannot distend the pelvis. And when you are working at the inlet or outlet, that is a location which restricts your wrist from making the movement, because there are bone all around. So this is the importance of robotic surgery. And this is the reason why the prostate became the first, and the word cancer and the word uterine cancer gave birth to the robotic, though I still feel that it is not popular. But the persons who are sort of looking at various sort of, literature are getting, and more surgeons are doing prosthetic surgeries, and now the radical hysterectomies, etc., which further led to the normal hysterectomy, and because of the pelvic bone which is there. Now, I think robotic surgery has been again acquired by the gynecologists much before. I'm talking of a therapeutic this thing. So like when we see laparoscopic cholecystectomy, the laparoscopic TLH also came the same way, became popular because it's a very common operation, and laparoscopy, gynecological laparoscopy, I think became standard with the TLH. And as we started LAVH and then we moved on to TLH. So what is gallbladder for us? I think it is TLH for all of you. So now I think if we look at the problem with the artificial, this is the robotic system which we are using at Max, our team is using. It is called Versius, and it is from Cambridge Medical Robotics. So it's a British robotic system. And as you see, the previous robotic system were all 7-8 millimeter punctures. With this robotic system, we have got 5 millimeter trocars, and all the arms are mobile, and you can move from one operation theater to another operation theater. That means that you don't have to dedicate an operation theater. You have 5 operation theater, you move 5 operation theaters, this robotic system, and it takes about 5-7 minutes just to wheel them. So now, again, I think I'm sure you all will be very happy. But today we did the 101 case of March. So today is what, 24th March. So from 1st March to 24th March, today we have done 101 robotic surgeries, which includes gallbladder, hernia, fundoplication, liver cyst, and appendicectomies, ventral hernia. So what I am trying to tell, see, look how soon it became popular. We started just a couple of months back, and today we are talking of 101 robotic surgeries from 1st March to 24th March. So you can sort of understand how fast we are doing. Another good point about this system is it's an open system. For me, it is especially interesting because there can be 10 surgeons sitting behind me and watching it. With the previous generation system, it's a console, which is to me, it looks a little claustrophobic, channel. You cannot communicate. So this is a beautiful open console. You can sit and operate. You can stand up and operate. You can raise the platform and operate. There can be our fascination, being passionate about training and teaching, is this. And this is one of the factors which I moved on to this system, because I know that because every 1st and 3rd Monday, we get a lot of trainees coming and our colleagues coming across the globe for 1 week or 2 weeks of training. And this is how we find that you don't have to have any training module. They have to just sit behind it, wear the glasses, and you can teach them what you want to teach them. And that is another beauty of this particular system. I'm sure you are all aware, you all have been doing robotic surgery much before we started. And the error is less, the safety features are more. And I would consider it as like a modern car. You have cameras all across, you have the audio video system, you have got the airbags, you have got the ABS, and you are a skid system protection. So I think it is there. But I think the previous robotic system is very expensive. This particular system is half, 40 or 50% of the cost of the previous system. I think because previously there was only one system in the market, so we had no choice. We have to pay whatever the patient were paying, 1.5 to 2 lakhs per procedure. But it is less than half, maybe about 40% of what the patients are paying now. So this, I feel, is the robotic system of the future. And I'm sure with more robotic systems coming in play, there will be more and more competition. And exactly what has happened with the laparoscopic surgery. The cameras were so expensive. Now everything has come down because of the numbers, because of the uses which are being done. And even the insurance companies are giving reimbursing for the laparoscopic surgery, and I'm soon it will have to reimburse for the robotic surgery. And there is going to be the patient who will demand. But I think what we have to ponder and also think is, you have to create a robotic team. The robotic team, because the bedside unit, the BSU, what we call is the bedside unit, how to place them, how to do the correction in the presentations. So that is what is important for the team. So I think laparoscopic surgery, for that matter, has taught us a lot about the team. So I think, you have to have a very well trained, and we are proud to say that in Max Institute, we have got 16 persons trained. These are 6 of us. We are consultants. We are trained for 4 days in proper training facility. And then we had cadaveric training. And then also our technicians have been trained. Our fellows have been trained. Our 4 fellows have been trained. So it's not that you have to operate in one operation theater. It can move anywhere. Then another fellow comes and helps you. Another technician comes and helps you. Another surgeon comes and helps you. So what I'm trying to say is that as you move your team also becomes bigger. And robotic team is much more crucial because of the high technology which is involved in this. So I would just about to conclude. I would just like to re-emphasize that minimal access surgery is not just a procedure. It is not a procedure. It is a very emotional thing. It is a philosophy of care. Previously, I think, with conventional surgery, the pain used to be so much, the scar used to be nasty. We were talking of a bigger incision for safety of the patient. We were not bothered about wound pain because the patients were sedated with morphine, pethidine, fortwin, Finargan. So we were not really much worried. But with this, I think it's a great philosophical change in the surgeon's mind and also the patient's mind. So for me, one single factor is not less pain, less that, but it is the philosophy. It has totally changed our philosophy, possibly what COVID has done for us 2 years back. So I think, this is what it has done. So this is the time to move, because unless you move, you cannot make progress and you will slide down. So you have to move. And this is possibly, I feel, and we realized last year that this is the time for us, with the new robotic system coming in, with the artificial intelligence there in that, and mobility of the instruments from one, possibilities of training. And this is what we decided, and we have moved for a better technology. But we are very sure that we are not going to change our ethics. We are not going to change our guidelines. Nothing changes with this. It is immortal. Wherever and whenever, whatever technology we are using, our ethics and guidelines remain the same. The surgeon is the leader. You all are the surgeons who are here. You have to create a team. And it is not only the surgical team, for anesthesia, physician, endocrinologist, psychologist. This is the team. And the team, to maintain communication, is important. You remember, as a childhood, we used to have that matchbox communication system from one room to another room. And some of our seniors would remember this. And it used to be great fun, having that. So that communication should not go. Communication should be transparent with the patient, the relations with your friends, with your colleagues. And another thing which has been added is the documentation. With all these things coming, documentation, if you see the patient 10 times, it doesn't matter, but you have to document 10 times. Even if you see the patient once and you document for 10 times, not bad. But seeing the patient 10 times, you have to have documentation because of the litigation issue. So what I feel is that we were always walking maybe we started flying, we started sailing, but when the spacecraft came, we acquired the skill set. The human being is acquired. So you're not born with the skills. You have to acquire as the time. So when we were doing the conventional surgery, we acquired the skills of conventional surgery. When we moved to laparoscopic surgery, we acquired the skill. It was not inherent in us. And now I think it looks as if we are going to the space, and robotic surgery possibly is the surgery of the space, possibly. And that is what we all have to acquire the skill. And it's not that you just sit on the console and start working. You have to acquire, because the patient safety is of utmost importance. Now you see the modern high value cars which have got 8 airbags just for the one passenger, which protects, previously it was just one airbag, but so safety is never enough. So whatever today's robotic system may be safe today, but tomorrow it is not, you will get a better system. And I feel that today's robotic system is just what laparoscopic system was 30 years back. It's just the beginning. So I'm sure it's going to, so why not adopt the technology at this stage, so that as the technology improves, as we have done LAVH and then moved on to TLH, LAVH disappeared. You see, so this is possibly, I feel that laparoscopy might in a couple of years in future may be called a robotic cholecystectomy or robotic hysterectomy rather than a TLH or a laparoscopic lap chole. So this is what, and I think also a little with experience, I've seen that it is not important for the patient also to have airbag, but it is important for surgeon also to have airbag, because the society has become litigant. So you should protect yourself, and you should be concerned about you and your team as much as you are concerned about the patient and the patient's relation. So you have to add safety things around you. And this is the familiar team which you see is a team of last 35 years, which stayed together till date, and I'm sure it will continue. And I'm also all our colleagues would identify each one of them, and this is what is the pleasure and I would say achievement. What we have is only because of the team. Otherwise, it's never possible. So the journey has started. The journey continues from conventional surgery to laparoscopy and laparoscopy to robotic surgery. I'm sure the future generation will tell us whether we were right or we were not right. So we have to continue moving in this direction. So thank you once again for this opportunity to just give a little feelings and what we felt and how we felt and how we have moved in this direction. So if there's anything you would like to know, I think you guys are much more experienced than we have, but still some things what possibly we see in future, we will be happy to share. Thank you so much.
Thank you, Dr. Chaube, for your lovely journey from laparoscopy to robotics. And as we all know that Dr. Chaube had been the pioneer in laparoscopic surgery, I still remember whenever you were operating in the other OT, and we used to go and watch that how he can operate from a keyhole surgery, how can he remove the gallbladder from there? And we really used to enjoy. I think it is your willpower which has brought you up to this the high level.
Thank you.
As you said that it's always a teamwork, that I also agree that it is always a teamwork. I think then they can tune better, because then they adapt to this thing, whatever the other person wants. So I think you can teach them better, and they can also teach further fellows. As you said that you've got 4 fellows in your hospital. And I think that day is not far away when I think you will be sitting in Delhi and operating in Bombay or in Germany. Thank you very much, Dr. Chaube.
Sure.
Can I say something, Harsha?
Yes, Dr. Malvika.
I just share one thing and ask a question to Dr. Chaube, that quite a few years back, way back, we done a conference in which I asked him to chair a session wherein Vinay and I had done combining two procedures. Like he mentioned, Dr. Philip, who had done a hysterectomy and who was, who had done the gallbladder surgery. Now, it all started with us when the patient wanted the gallbladder to be removed along with the uterus removal, and we were not sure whether we should, and we checked out the record, there was nothing. But thereafter, we started doing this procedure, like combining gallbladder with hysterectomy. And I remember Pradeep Bhai sitting there, and he also that time brought out this medical legal problem. If there was a complication, who would be taking the onus on that? So I would like to ask Dr. Chaube, in case you are doing combining surgeries now, and what is your thought process on that?
I think, there are certain surgeries, Mala, this is very relevant because what we have seen that our patients of gallbladder stones, which is, of course, the commonest thing, will have many times problem with either fibroid or some endometriosis or some cyst or even TLH, or the patient will go for TLH to Dr. Vivek Marwa and then has got a gallstone also. So when you have a combined system, I think these surgeries can be combined without any hesitation, because we know the problem of hysterectomy will be different than the problem of gallbladder surgery. But we have the reservation only for the prosthetic surgeries, laparoscopic, and for example, hernia. So when you are putting in a prosthesis, yes, and you are doing a hysterectomy, then we would not like to, because you are opening the vagina and suturing the vagina, and the place is contaminated. What we do is that for all other procedures, we combined. There is no problem at all. No. But when it comes to repair of hernia, we avoid. We don't do this during hysterectomy. Yes. But if it is a myoma, fibroid, we are happy. We have the same operation theater complex, same anesthetics, same equipment, and same our long-standing gynecologist, laparoscopic gynecologist, Dr. Vivek Marwa. We have a good tuning, so you can do that.
Wonderful. Thank you so much.
And Dr. Chaube, I just loved what you said. Learn the skills you are not born with. Simply wonderful, and it holds so well with you.
Thank you. Thank you.
I admire the teamwork that Dr. Chaube propagates. The way he has formed his team and the way he encourages the team members, it's amazing. We've all been learned under him, and this is the best part. I think he's got exceptional technical skills, but he would still praise the junior most person doing the surgery.
He also takes advice from the junior most. I mean, that's a lack of ego, and I think it's amazing. It's amazing.
But that is the most important thing, because everybody present is going to be involved in the surgery. And, it's amazing how even the OT technician may just give you a tip. These are amazing things which can come out. So it's very important to take the tips from everybody. It's a group which works together, team which works together.
Well, I think, this is very important, because all of us seniors should understand that our youngsters should start from where we finish. So I think they had to be more dexterous, more dynamic, much better crafty surgeons, good human beings, well-meaning advices. So I think, I would, like previously, all the laparoscopic surgeon, when we were doing, I think we were getting a standing ovation as a magician, because nobody 30 years back thought that gallbladder can be removed and, you just walk out and the patient is walking in the evening. But yes, I don't know, I never liked that word, because magician is not for me, it's not a good word, because magician is the person who keeps secret to himself. So surgeon should not be a magician. Surgeon should be a person who teaches. Yeah, and his credential should be valued by the persons who I may teach who are doing far better than him. So that is fun. Today, what I am enjoying is my colleagues are doing much better than what I can do. So, that is a pleasure. That is a pleasure which keeps you going.
Really?
For that, the credit goes to you, Dr. Chaube, because I think you are a very good teacher, and I think you can trust your juniors also.
Really?
That's very good. That's very important to me. I think.
Dr. Mamta, for your comments, please. Dr. Mamta?
Yeah, can you hear me?
Yes, we can hear you, ma'am.
Am I audible?
Yes, ma'am, you're
Yes.
audible.
Yeah. Thank you. Yeah. Thank you, Dr. Chaube, sir. In fact, I had the opportunity to learn endoscopy when I was in Gangaram, and this is how it began, my interest and my, in fact, journey, I must say, long time back, I think almost 2 decades back when I joined Gangaram Hospital. So it was a good learning experience, and I know how here you are. And your presentation has been so splendid and so absorbing that I do not see that there are any questions for you. But, so if anyone wants to ask a question, Dr. Kanika?
Yeah. Frankly speaking, the questions can go on and on if I start asking, sir, but I think I should give the opportunity to others, because I was always eating his head when I was with him in his team. There used to be questions bombarding from all angles, and he even made me do a lap chole and a hernia. I'm in his team, so that's I'm always very indebted to him for that. And basically, as he says, the best part is to learn the camera first. If a person can really show a good camera, that person can only be a good surgeon. If you don't know what the surgeon wants, if you're a good assistant, then only can you be a good surgeon. So observing, learning from observation is the first and foremost step, and I learned it from him. And of course, as I said, I think Vandana can vouch for that, the teamwork, that the team that he creates.
I completely endorse that.
And so, in fact, I must say the journey began from the endoscopy department there in the surgery for us people, the beginners and the learners, So the credit goes to you, sir. Thank you so much.
Thank you very much.
So, can I ask one question? So, in this journey of of acquiring robotic skills and then performing robotic surgeries, what is the single most important thing to keep in mind when we begin? I mean, where should, like, since we are talking to the gynecologists and all, how would you like to give a word of advice as to how they should proceed in training in Vercius, and how is Vercius helpful and beneficial in gynecology?
Well, I think the biggest benefit which I see is as I said, like your learning curve will become short, because it is not only what you're doing, but I think if suppose one person is doing and there are 5% sitting behind and looking at the 3D dimension, so I think they convert again, as we converted our 3-dimensional images to 2-dimensional, and now we have gone back to the 3-dimensional. So I think they will easily convert. Second point, I always maintain, as we have also followed, that when you want to get worse with the equipment and high technology, I think it is better to do simpler procedures. So, for example, the laparoscopy, we all became skillful because of the gallbladder. The gynecologists become skillful because of the laparoscopic hysterectomy. Because, like it's a common procedure. Day in and day out, you do the thing. You do let your seniors see that you should. So what I feel is that before venturing into the, say, suppose I would say the radical hysterectomy is good, robotically is fantastic, but you should start your career with a simple hysterectomies, do as much as you can, move back to laparoscopy if you find difficulty, if you find some confusion. confusion. Then you simply, and another versus advantage is that its ports are 5 mm. You just pull out your robotic instrument and and the port placement is exactly the same. Like in the previous generation Intuitive, you have to place only all in one direction, in one line. But with Vercius, you can put ports anywhere in the abdomen. It doesn't matter. So technically, I think you just pull out that and start working as you were doing before.
So would you advise an open surgeon to directly switch over to robotic, or would you?
No, robotic to laparoscopy, na? See, we all are doing laparoscopic surgery. So by chance, if there is a malfunctioning or you're disoriented with the robot, you're not able to manipulate, then simply pull out the robotic instruments and put your laparoscopic instruments and continue.
So one has to be well versed with laparoscopy first.
Of course, yes. I would say so. I would say so. Because the laparoscopy, you have to have angulation, angle of attack, angle of vision, the angle of retraction. Those robotic, the principles remain the laparoscopic principles. That remains the same. But yes, now previously we used to say, when you are finding difficulty in laparoscopy, move on to conventional surgery, because that was our mainstay. Now our mainstay is laparoscopy. So when you find it difficult with a robotic surgery, you move on to a conventional laparoscopy.
Thank you so much, respected chairpersons. And thank you, sir, for that scintillating talk, which was really inspiring, especially for budding endoscopic surgeons like me, who can just hope to become a stalwart like you one day. But you have taught us to go for the stars and carve a niche for ourselves. And thank you so much for that really inspiring talk. And thank you for sharing our journey with us, sir. It was an honor having you with us, and I hope you could stay with us for the rest of the webinar. Thank you, sir, and thank you, respected chairperson.
Okay, thank you. Bye-bye. Bye.
So with this, we move to the most anticipated part of our webinar, which is the panel discussion. And we have a galaxy of stalwarts with here today who are going to take you through the different aspects of robotic surgery, and I am sure that after the panel you're going to feel that robotics is not that difficult after all. So without further ado, let me introduce the moderators of this panel discussion. Shivam, can I have the slides, please? Yeah. So our moderators are none other than our beloved Dr. Kanika Jain. She needs no introduction. Madam is the chairperson Endoscopy Committee 2021-23, Vice President AOGD 2020-21. Whatever her accomplishment is, all I would like to say about her, that is, she's gem of a person, and I think that is the thing that really matters in a person. So I'm really fortunate to be working with her. Welcome, ma'am. And to moderate with her, we have Professor Indu Chawla. Madam is Professor and Consultant, Dr. Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RML Hospital, New Delhi, as well as the ex-HOD of the same department. She is the Executive Committee member of the various bodies like AOGD, NARCHI, and her special area of interest is gynae endoscopic surgery. We have an array of wonderful robotic surgeons with us today. First and foremost is Dr. Vandana Soni. Madam is Director, Max Institute of Laparoscopic, Endoscopic and Bariatric Surgery, Max Saket. She has a surgical experience of over 25 years and specializes in minimal access and bariatric surgery. She has been conferred multiple awards, chiefly the Surgeon of Excellence for Bariatric Surgery by the Surgical Review Corporation USA. She has had multiple publications to her credit, and we welcome you, ma'am, and look forward to hearing you. Next we have Dr. Mala Srivastava. Ma'am is Senior Consultant and Professor at Sir Gangaram Hospital, New Delhi, Vice President-elect of ISOPARB 2023-24, past President AOGD 2020 and 21, and again is a recipient of multiple awards, and her special area of interest is gynae oncology, gynae endoscopic surgery and gynae robotic surgeries. Welcome, ma'am. Our next uh, very esteemed faculty panelist is Dr. Dinesh Kansal. Madam is President of Delhi Gynae Endoscopic Society, also an IEGE Managing Committee member, and she's the Director and Head at BL Kapoor Hospital, Delhi. She has been awarded various awards such as the Satyapal Award, the Times of India Excellence Award, and Abdul Kalam Award. Welcome, ma'am. Next, we have Dr. Rama Joshi. Madam is Principal Director and HOD Gynae Oncology and Robotic Surgery at FMRI Gurugram, and she's a dedicated gynae oncologist, gynae oncosurgeon, and robotic surgeon. She's the President, Association of Gynecological Oncologists of India 2016-17, and Honorary Secretary General of AGOI 2011-2015. Again, she's been awarded with multiple awards and honors, including 6 gold medals in her post-graduation. Welcome, ma'am. Our next panelist is Dr. Vipin Tyagi. Sir is consultant urologist, kidney transplant and robotic surgeon, and has received robotic training at University of Miami, Florida Hospital. His special interest is in renal transplantation, urology, cancer, and robotic surgery, and he has multiple awards and publications to his credit. We welcome you, sir. Last but not the least, we have the affable Dr. Anupma Bahadur with us. Madam is Professor and Unit Head, Department of Obs and Gynae at the picturesque AIMS Rishikesh. She's also Head Division of Robotic Surgery at the same institute, and her special area of interest is reproductive medicine and infertility, minimal invasive surgery, especially robotic surgery, medical education, and high-risk pregnancy. And she has even authored a book on robotic gynecological surgery, and I am sure that we have lots to learn from her. So without further ado, I hand over to Dr. Kanika and Dr. Indu to begin the panel discussion.
Thanks, Swati, for the kind words, and thanks Team IAG and Team AOGD for giving us this opportunity to moderate this panel in which I think ultimate stalwarts are participating, and it's a pleasure and honor to moderate this panel. So I welcome you all. We are all aware that Da Vinci system was introduced in 2000, and it was FDA approved in 2005 for gynae surgery. It's being used increasingly all across the world. In India also, I think it's being used, but it's still mainly confined to bigger institutions because of the cost. A number of questions arise, like with so many benefits of robotic surgery, as Sir Chaube highlighted, should all of us maybe in next 2 decades shift to robotic surgery, or somebody who's doing open surgery now should learn laparoscopic surgery first and then move on to robotic? And what are the various challenges and other things, So to discuss all these things, we have a galaxy of superstars, who are just stalwarts in their own fields. And we'll start with Dr. Vandana Soni, our glamorous, dynamic lady, opening batch person. So over to Dr. Vandana, and Dr. Kanika will take over from here.
So hello, Dr.
Thank
Vandana.
you so much. Yeah, hello, Kanika.
And we would like you to enlighten our audience on if they want to really progress on to a robotic, that is a robot-assisted laparoscopic surgery, or what are the advantages, disadvantages. So the first question directed towards you is, what are the technical advantages of that independent robotic arm that Sir was talking about? What are the technical advances?
Dr. Kanika, may I share my screen so that I can show the...
Yeah, you can. Shivam, can you
go on to share screen, Vandana?
He'll have to allow me to share.
Shivam?
You can share.
Okay, let
Yes,
me
ma'am.
see. Yeah. So... all right. Okay, so share screen and this desktop if I share?
Yeah, we can see.
We can see.
Can you
I'm
share?
sharing.
Okay. Oh, all right. So correct. If I may, oh, I think you'll have to restart it. So can you just restart this video? Right. And can you just pause there, Shivam? So, okay. So as you can see, there was in Dr. Chaube's presentation, he showed the single BSU or bedside unit, as we call it, independent bedside unit, which is part of the Versius robotic system. So what you see here is these three robotic arms which are independently positioned. And this is just to highlight the features of this robotic system. So as we can see that the independent bedside units actually give us so much of flexibility. Without having to change the position of the patient, the position of the operative field can be changed within 5 to 7 minutes simply by taking those instruments out and reorienting or repositioning the bedside units. So it takes about 5 to 7 minutes. So that's an enormous amount of flexibility in performing even more than one procedure, or in performing a surgery which requires moving into the various quadrants of the abdomen, for example, bariatric surgery. So you don't have to do a one single quadrant surgery, which was what was being done previously in the previous robots. Secondly, what has also previously been mentioned, that the robot is no longer restricted to a single OR. That means you don't have to have a dedicated robotic OR. The robot is transferable. So because of the mobility, the moment you've finished one case, and that is how we have been able to achieve that those numbers of over 100 robotic procedures in less than a month, is because there are 2 or 3 ORs where simultaneously we can perform robots. So one is over, and while that patient is being reversed, the other one gets prepared, and you simply wheel the console into the other OR. Thirdly is the cost factor. Again, the cost factor is significantly different. And once with the patent that the Da Vinci had over the robotic system being over, and more companies jumping into this bandwagon, we are going to have robots coming in from from Medtronics, from J&J. So one can expect a huge amount of competition, and it is going to become financially viable even for smaller centers to have this introduced. And as you can see that the surgical console on the left hand corner, which is there, is an open console. It has armrests and a stable chair for the surgeon to sit. In fact, this console gives the flexibility of the surgeon to stand and operate also. So the height of the console can be adjusted. You want to sit and operate, fine. You want to stand and operate, if you're more comfortable like that, you just have to raise the armrest and the screen of the console. Thirdly, you can see that the console screen and the slave screen or the monitor on next to the bedside both have the same screens. So what the surgeon is seeing, exactly the bedside assistant is also seeing. So we can start the video now, Shivam. So these are a few advantages, as you can see, and this is part of the training program. This was when Dr. Chaube went and trained. As you can see, this is the training OR that the Versius, the CMR or the Cambridge Medical Research has in Goa. And as you can see that screen that was there, this is a virtual training which is going on, and then they also make you work on animal tissues. So I think anything else, anything further you'd like to know, we can.
Yeah, basically, can you just tell us what is the information that is normally shared between the operating surgeon and the assistant surgeon at all times?
So that's what I wanted to highlight in terms of the monitor. So the head-up display, whether it is the surgical console or whether it is next to the patient bedside, both of them have the same screen. They have exactly the same screen. So they are seeing exactly the same thing, except the 3D effect. The 3D effect is with the operating surgeon. So his vision is 3D, and what the bedside assistant is seeing is 2D. Also, because it is an open console, there is a direct communication between the surgeon and the bedside assistant, or the patient, the surgeon standing next to the patient.
Surgeon doesn't have to raise his head up to get reoriented.
Yes, yes, or speak into a mic. So that is not there. So there is no communication gap.
Okay. So that's nice.
All right. And if there is the assistant that has to say anything, that also can be immediately, conveyed directly to the operating surgeon. And also when we come to the next video, I would like to show, in the bedside units, what are the safety features which are there, and, the other options which make it so flexible.
Okay,
So
the assistant is a laparoscopic surgeon, and the
can you just stop it? Yeah.
the main
So
surgeon
as
is console, and they are very
yeah. So exactly. So it is a well communicating, a harmonious, chain which is formed. There is no break in the chain anywhere, and right from a free communication, even to the dismantling and having to convert to a conventional laparoscopy is just a matter of seconds, not even minutes. It takes about anything from 20 to 25 seconds to just move those bedside units away. You just have to disengage them, and they although they are, I think, over a ton each, but they can be moved so easily, so smoothly, because of the wheels, that the moment you disengage them, they can be pushed away, and it's just a matter of seconds.
Undocking is very fast, you say?
Very, very fast. Yes, yes,
normal
yes.
instruments, in operative instruments.
Exactly. Yeah. So all of these bedside units are interconnected. They are communicating with each other. They are communicating with the surgical console. So the surgeon can stop the surgery immediately and disengage. Or if you see that red button there, can you see the red button on the video? That is, so if at any point of time, if the assistant feels that there is a danger, or safety is being breached, he can simply press that button and stop the BSU there and then. So these safety features are being given. Can we start the video? So as you can see, these are the different buttons which are provided. The Z you can see is for awakening the console. The 4 pointing in different corners is for orienting. The plus and minus is for raising the height or lowering the height. This is to resume. In case you stop and then everything is safe, you can press the resume button. And the last button which was there was to silence the alarm. So this is how the BSU is draped. As you can see, these drapes are provided currently by CMR. And then it completely sterilizes the BSU. There are 2-3 points where the drapes are fixed. And the point which is, and this is the sleeping mode. So that means now the BSU is ready to be docked.
Very nice videos. Thank you. So what is the protocol you follow before starting any robotic procedure? Like normally we have protocols set up for everything.
So there's a checklist. Yeah. There is a checklist. Yeah. So there is a checklist which is there before the surgery. So this is the checklist which is followed even before the operating surgeon enters the OR. So there are certain prerequisites for using Perseus. One is that none of the BSUs as well as the surgical consoles should have been switched off for more than 24 hours. That means it should have been operational 24 hours before. In case not, you have to operate it and check the functionality of each before connecting and assuming that you can proceed with the procedure. One is that. Secondly, you have to see that the monitor on the surgical console, the armrests and everything is, the armrest can actually be retracted back, and it can be compacted into a very a much smaller space for storage. So you have to disengage all that and bring it into an operating mode. That means the handrest for the surgeons should be in the optimal position. They have to be pulled out. Then connecting the BSUs, there are different connections. Each BSU can be independently connected to the surgical console, or like a daisy chain. That means one BSU to the other BSU to the third BSU, and that BSU to the surgical console. So this is the checklist which is performed before surgery. Then before starting surgery, it is important that the operating surgeon confirms that he's using the correct degree of the telescope, that all the BSUs are properly draped, that the electrosurgical units are all in position, and all safety features. That means orientation of the bedside units. Yes. So I showed you those four flickering arrows which were pointing in the different directions. So when the BSUs are positioned, they should all be oriented in a single direction. So that is part of the checklist also. These are all safety features, so that once they will all move in cohesion and in the same direction then, in response to the surgeon's operating movements. So that is there. And then once the surgery is over, you have to ensure that the recording is stopped, that all the operating arms have been, it is called RCS, release the tissue, close the jaws, and straighten the instrument. So the RCS has to be followed at the end of the surgery before the instrument is withdrawn. So these are the safety features. There's a checklist, and then the nurse will read out, and everybody has to, both the assistant and the surgeon has to confirm that yes, it has all been done.
Yeah, that's very nice. If there are proper SOPs in place, nothing goes wrong. Definitely the complication is much less. And as we can see, it's basically the comfort of the surgeon is ensured. So the as they say, the surgical career graph can be prolonged for a surgeon, rather than somebody who starts rusting out or maybe having musculoskeletal problems and all with a prolonged laparoscopic surgery. So that is taken good care of with a robotic.
Yeah, that is taken care of. Yes. So
what are the other, as I said, this is maybe one of the advantages. So what are the other advantages of a robotic approach in gynecology in particular?
Robotic approach, I see gynecology is, I think it has been kind of, designed for both for laparoscopy and now of course for robotic. Why? Because it's standalone, and it can be, the uterus can be so beautifully lifted up. In fact, most of the adhesions can be also so easily approached. There is no what should I say, when you start the surgery, I think there is no vital organ or vital structure or major vascular structure which can come in the way. So the two uterines, I'm sure you are all well aware of, and I would refrain from commenting anything more on gynae surgery. But yes, I would say, because that organ is standalone, it is quite isolated, it is not within or in any way encompassed by any other vital organ around it. It is, I think, a very safe surgery to be approached laparoscopic, and anything that can be done laparoscopically can be done even more precisely robotically.
Well, it's not standalone acts altogether. We have the
and I'll tell you one more thing. Especially Suppose you have a large myoma or a very large uterus, so right now the difficulty is only in reaching the operating field with the camera, with the telescope. But your working instruments, there is so much of flexibility in overcoming that large size tumor and then reaching the.
Are there any areas which further need some, there is a scope of improvement in that vis-a-vis the.
Tremendously. I think Versius has just started out, I think. In fact, the Versius Robotics is a system which has been designed by surgeons for surgeons. So this engineering, and that is why if you go through the system, you will realize that it is there to overcome all the problems that the surgeons face laparoscopically. So, however, in terms of instrumentation, yes, I'm sure there can be better instruments, and those are going to come by and by. With the current system, they have the bipolar in it, but higher energy sources like harmonic and ligashore, those yet have to be designed for this robot. And then finally the staplers. So I think these are the two things which are still missing. Once these are in place, then I think then one can go even in terms of
comfortable with the intuitive system also. That's much better, very comfortable as compared to laparoscopy. So just one last question for you, Vandana. What would be the situations in which you would like to avoid the robotic approach as compared to laparoscopy vis-a-vis gynae?
Okay, so I think in robotics, especially any surgery which involves a small working space, that means a virtual space. So right now, I think this is a bit of a drawback. The pre-peritoneal space that we create does not have sufficient space to give us that length to work in. So those are surgeries which should be avoided. Also, I think surgery where things like portal hyper, anything which is to be avoided in laparoscopy should also be preferably avoided for laparoscopy. Things which patients who are high risk for GA and all, because in robotic again you will require GA in these patients.
And I think with our system, maybe somebody who's very short statured and has a very stocked abdomen.
Small, yes, a small abdomen. Again, that's exactly because you require that width of spacing. Correct.
So thanks, Vandana, for
my pleasure.
The basics and an overview of the system. So from basics, we move on to the specific surgeries. So we all have been doing myomectomy for decades, and myomectomy, though being done laparoscopically, most of the time it is still being done by open technique. Though number of myomectomies being done by robot has increased. So the question is it better done by robotic, or there are still challenges? To discuss all these issues, we have a very senior consultant from Sir Gangaram Hospital, Dr. Mala Srivastav. Madam is a well-known figure. We all know her. She is an excellent robotic surgeon. And over to you, Dr. Mala.
So Dr. Mala, let me ask you a few questions. Dr. Mala, what are the steps or the areas where the robo-assistic laparoscopic myomectomy can have an edge over the traditional laparoscopy that we see?
Thanks, Dr. Indu, and thanks, Dr. Kanika. See, one thing I want to tell the audience, that we know two surgeons who directly converted from open to robotic surgeon. Dr. Amita Maheshwari from Tata Memorial Hospital, Mumbai, and Dr. Soma Shekharan. They were never laparoscopic surgeons.
That's excellent.
They just converted from open to robotic surgery, and they are excellent robotic surgeons. So don't be disheartened. You can learn robotic surgeries in a very short time. Definitely, robots are a new system as artificial intelligence equipped with 3D cameras, and it's a new system, and it's going to stay, and it's going to make the surgeries minimally invasive more and more popular. Now coming to the myomectomies. See, myomectomies, the principle is the same whether we do it open, whether we do it laparoscopically, or whether we do it robotically. Definitely, when we are doing robotic surgery, we see better, we operate better, there is a precision surgery. We have fine instruments that have 7 degrees of movement and 3D vision. So we do precision surgery while we are doing myomectomy as well. The principles remains the same. You have to give vasopressin to avoid to decrease the vascularity of the tumor. You give and plan the incision according to the number, size of the myoma, and then enucleate the myoma and then do the repair. I think, Swati, the video was supposed to be on. So when we do suturing with the robotic, we do a more precise suturing, more as good as if we are doing a open surgery. But definitely all experienced laparoscopic surgeons can do good precise repair of the myoma bed and give good scar as well.
Can we have the video on?
Shiva, can you please play Dr. Yes. Yeah.
So this video, this girl was an unmarried girl, 22-year-old. She had a big myoma, posterior lower uterine segment myoma. The principles, as I said, remains the same. You have to give vasopressin, you have to plan your incision, and then you have to enucleate the myoma and then repair the bed as in multiple layers as we do in the open surgery as well as in the laparoscopic surgery. So definitely this was a huge myoma, almost 18 weeks or the size of the 18 weeks uterus. And with the help of the robotics, we were able to do a precise surgery and give a good scar to her at the end of the surgery.
So, Dr. Mala, is intracapsular myomectomy better with the robotic assistant, or is it the same with laparoscopy?
See, basically it depends on the skill of the surgeon. You may have the best equipment, but if you're not a skilled surgeon, you may not do a good job with it. So whether you're a laparoscopic surgeon or robotic surgeon, if you are a skilled person, you will do good job with either of them. But definitely there is an edge with the robotics because you have 3D vision. Of course, even in laparoscopy, you have 3D cameras, you have 3D vision in laparoscopy as well. But with robotics, you see, there are finer instruments with 7-degree movement. So you are working very closely, you're seeing well, you're doing well, and your surgery is a precision surgery. So intracapsular definitely has an edge over the laparoscopic surgery. Technically is more difficult procedure, sometimes laparoscopy, but then in suturing, especially with the robotic, is very easy and it comes very nicely. So sometimes, of course, robotics may take longer time than the conventional laparoscopy, but then the repair, multi-layered repair that we require in the myoma bed is definitely achieved much easier.
Dr. Mala, can you highlight on the what is hybrid robotic myomectomy?
See, hybrid procedures are procedures when we mix up two kind of procedures like laparoscopy and open procedure, laparoscopic and robotic procedure. So hybrid procedures can be mixing of two kinds of procedures.
Like in this,
like suppose, when we do myomectomies, either laparoscopically or robotically, we have to remove it either by morcellation or by just increasing giving a small incision and doing the cold knife morcellation. Instead of power morcellation, we can also do cold knife morcellation of the myoma to retrieve it from the abdominal cavity. And some surgeons, especially Dr. Rama Sinha from Hyderabad, she is very popular for doing the hybrid myomectomies. What she does, She removes the myoma laparoscopically, and then she docks and do the suturing robotically. Because definitely suturing is more precise with robotic arms, and it's easier and gives multi-layered closure of the myomic bed. So by hybrid procedures can be mixing of two procedures, two methods of operating.
In what conditions would you like to resort to a hybrid technique?
Basically, if we have a multiple big myomas, then in that case also we would like to switch over to the hybrid myomectomies. Suppose even we have a single big myoma that we can quickly remove with laparoscopy and then switch over to the robotic to do the suturing. But the idea is to reduce the operating time for the surgeons and give lesser anesthesia to the patients.
What about retrieving the specimen?
We can do either by the in-bag morcellation, power morcellation, or by, we can also do cold knife morcellation, that you give a smaller, bigger incision and do the morcellation by cutting the specimen or by doing the, cutting the instruments with, cutting the myoma with the knife, cold knife. And you can take it out instead of power morcellation.
How would you compare the reproductive outcomes between open, laparoscopic, or robotic assisted laparoscopic myomectomy?
So far as the reproductive outcome is concerned, it's the same. Either we do open myomectomy, laparoscopic myomectomy, or robotic myomectomy. The long-term outcome remains the same, whether it's the fertility or it's whether the improvement in the menstrual cycle. This outcome, long-term outcome is same whether you do open surgeries, myomectomies, open laparoscopic myomectomies, or robotic myomectomies. The outcome is the same as well as the fertility is concerned or whether it's the menstrual outcome is concerned.
Are there any limitations? Any limitations to robotic assisted laparoscopic myomectomy?
See, basically, as earlier it also was told, if the patient is very short, stalking, the abdominal cavity is very small, and the myoma is very big, then in that case, we have problem in placing the instrument, docking the instrument. In that case, there may be some limitation of doing robotic myomectomies. And especially if there is a huge myoma, suppose it is a 28 weeks myoma or 30 weeks myoma, it's very difficult to place the instruments and dock the arms, robotic arms, and do the surgery. We have done robotic myomectomies in patients up to 18 to 20 weeks of myoma. But then larger than that, there is very lesser space in the abdomen and it's very difficult to manipulate the instruments. In that case, there can be difficulty because when we are doing laparoscopy, we can twist and turn the myomas, but that amount of mobility is not present in robotic myomectomies. We cannot twist because the arms are docked and they are almost fixed. So that can be one of the limitations. But definitely if there are multiple large myomas, sometimes it may be difficult to do robotic myomectomy.
There's a question for you. What are the contraindications for robotic assisted lap myomectomy?
No, there's no contraindication. It depends on the skill of the surgeon. You may be really skilled. You can do any surgeries robotically. So every surgeon should know their limitation. If my limitation is up to 18 weeks myoma, I should stick to it. If my limitation is up to 14 weeks myoma, I should stick to it. Because patients do not have any learning curve. It's the surgeons who have the learning curve. So we build up our skill over a period of time and gradually we upgrade our skills. So every surgeon should know what is their safety levels and safety limitations. And we should do all the surgeries, pick and choose and select our cases very intelligently. There is no harm in doing open myomectomies. There's no harm in doing laparoscopic myomectomies, and there's no harm that we have to do robotic myomectomies. We have to pick and choose our cases.
Mansell wanted to say something in, I think. Madam, yeah.
Thank you, Dr. Indu. Dr. Bala, like we spoke about 3D camera in laparoscopy as well, but the difference which I find is the robotic camera is fixed. You don't have those tremors or unnecessary movements which your assistant is bound to have, being a human hand. And the camera is totally under our control. Sometimes you may not have a good assistant, so camera keeps on, not focusing where we want. And that I find very important. And second is, if the assistant is not good, she may not place the myoma screw exactly where we want, because very often we use an assistant for that. And so in laparoscopy, we go to the other side and put the myoma screw or tenaculum and give it to the assistant. Here you're sitting at the console, so this is one thing more which I miss.
And the advantage of robotic, I would say, is the articulated instrument. So we can go into the, especially the lower cervical fibroids and the posterior lower segment fibroids, where stitching may become technically difficult. That becomes much, much easier with the robot.
So, Dr. Mala, there's another question. What is the conversion rate? From the audience, there's a question, like robotic. It's not clear to open or laparoscopy.
Basically, we have to select your cases. That is the main thing, that you have to select your cases judiciously. If like in our practice, we never had any conversion rates. Initially, when we started in 2011, then we had 1 or 2 conversion rates. But now, over a period of so many years, we don't have conversion rates. But you have to pick and choose your cases very judiciously.
Thank you, Dr. Mala. From myomectomy, we move on to more complex cases, that is gynae-oncology. Endometrial cancer is a very common malignancy we encounter, and we all know its incidence is increasing. And ever since we have been postgraduates, there was a question, lymphadenectomy, yes, no, in this situation, no lymphadenectomy. And we want to know the lymph node status because it helps to prognosticate and whether patient needs adjuvant therapy. So if we do lymphadenectomy in all cases, we know there are so many complications of lymphadenectomy. And if we go by Mayo's criteria, it has high sensitivity but low specificity. So now we have an alternative. It's Sentinel lymph node mapping. It provides an alternative to the above solutions, like above problems. So, Dr. Kansal, so maybe there are many postgraduates and people new to it. What is Sentinel lymph node and how do you do it? So can we have the video and the details? What is Sentinel lymph node?
Thank you. First of all, thanks for inviting me, Dr. Kanika, Dr. Indu, and Swati. And let's start with the Sentinel node is, as the name suggests. Let's have the video first otherwise. It's the first.
Hello friends, I'm Dr. Dinesh Kansal from BL Kapoor Hospital, Delhi. And here we are doing sentinel node dissection in a low risk endometrial cancer on the right side. We are opening retroperitoneum by taking an incision parallel to the infundibulopelvic ligament. So we are trying to locate the ureter on the left side. On the right side, that's the ureter. And we can see the external iliac artery and vein laterally. So now we are dissecting parallel to the obliterated internal iliac. And we have injected methylene blue as well as ICG dye intracervically, and we are beginning to see the lymphatics coming from right parametrium laterally to the sentinel node. We can see the blue sentinel node, and these lymphatics are seen crossing over the obliterated internal iliac. We'll make it little more clear. And because robot doesn't have overlay mode, that's why we injected methylene blue too. These are the lymphatics coming laterally to the sentinel node. So we pick up the tissue and dissect the node, but we have to be sure that the sentinel node proper is this one. So we put on the fluorescent mode. That's a dark mode, and here we can see it's not fluorescent, so we just discard this tissue. and go further and deeper. Again, put on the fluorescent mode. We can see this is the correct lymph node. It may not be a large node. This is sent for a permanent section, that is thin sections after the immunohistochemistry for cytokeratin 19 and
Yeah. So we had a short clip which shows sentinel node is the first node which drains the malignant tumor, and it is more likely to contain micrometastasis and which may upgrade the stage. And as Dr. Indu said, because there's a lot of morbidity associated with lymphadenectomies, the time factor, the transfusions, injury to the blood vessels and the nerves, and also the lymphedema and lymphosene. So we had this procedure. As you saw, it was very quick. We locate the sentinel lymph node and we take it out. And as far as results are concerned, it is giving better results. That is 18 to 20% upstaging the disease. And it is especially good for low risk endometrial cancers, that is stage 1A, where the involvement of the myomectomy is less than 50%, and grade 1 or grade 2. Though the trials have shown its efficacy even in higher grades in all the stages, but especially in low risk cases, it has been well proven. And the sentinel node, it may contain few tumor cells, which may not upstage the disease. It may be more than that. So it is the microscopic examination. So it consists of three things. First is identification. For identification, we can use methylene blue, as we showed here, which can be visible to the naked eye, but the effect is not as good as the ICG dye. For ICG dye, we have to have the infrared enabled camera, whether you are doing laparoscopic or robotic. So that is a must, and all the robots have this firefly mode where you can see the node shining, as we saw over here. And the dye has to be injected either intracervically, the most standard place where we inject. And people have tried injecting hysteroscopically also, or laparoscopically into the fundus also. But the intracervical has given the maximum yield of the sentinel node, like you've seen in most cases, the sentinel node. So everybody is now sticking to the intracervical injection. You get the ICG dye in a vial, you dilute it with normal distilled water, and you inject 4 ml, that is 1 ml deep, 1 ml superficial on each side. And that should be just before starting the procedure. You inject the dye, put the manipulator, and then we start doing laparoscopic dissection. We should not be wasting time, because within 5 to 15 minutes, we should be able to locate the sentinel. If we don't do that, the dye will spread to other nodes, then you won't know which is the primary lymph node. So this is the first lymph node, because later on you will see the others, they are called echelon nodes, which are not so important. And if we dissect 1 or 2 sentinel nodes and give it to the pathologist would do a wonderful job taking very thin sections, because that becomes time consuming, and you cannot do so for all the lymph nodes. So compared to lymphadenectomy, complete lymphadenectomy, you have better chances of locating a micrometastasis.
So, ma'am, you prefer to use both endocyanine and methylene blue?
No, normally we have striker camera which has overlay mode. That is, in laparoscopy mode itself, you can see the fluorescence also. Yeah. But in robot, we don't have this overlay mode, as I said. So either you will see the laparoscopic mode or you will see the dark mode. So you cannot do dissection in the dark mode. So you have to switch it on and off. So here, just for the sake of demonstration, I used both of them, but either of them is okay. But ICG dye is superior to, as far as results are concerned, superior to the blue dye.
So as I understand, it can avoid the complications of lymphadenectomy if done properly. So does robot have an edge over traditional laparoscopy in sentinel lymph node mapping?
Yeah, as Dr. Chaube said, we have wonderful depth in this. And because, when we used to do 2D laparoscopy, And we thought this is external iliac artery vein and next is the internal iliac artery. But now when we do the 3D laparoscopy or 3D robot, we see, they're like this. So there's a depth thing, internal iliac goes from behind. So this anatomy you can understand only in a 3D vision. And as I said earlier, the camera is so static and we can take it forward and backward, by a fraction of centimeter. And that does the job so wonderfully. Precision is a great thing in robotics, which is not possible in laparoscopy.
Okay. So,
As Dr. Kanika, yeah, dexterity of the tips of the instruments, you can finish the surgery much faster and less chances of damage to the surrounding structures, because you can see even the small blood vessels which you can take very conveniently.
So the next question comes, it's accuracy. So what is the detection rate and sensitivity of this mapping in early stage? Low risk endometrial CA.
There have been many trials, and the largest one was FIRE's trial. And it shows that negativity rate or false, the negativity rate which is detected by this, if it's negative lymph node, it is 99.6%, almost 100%. And if it says that the lymph node is positive, then it is 97% positive. So it's almost 100%. And why it is important? Because there were two schools of thought. Like Tata Hospital, it said low risk cancer, don't do lymphadenectomy. And there are surgeons who say low risk cancer, do complete lymphadenectomy. So, this is a thing which is in between. We don't want to miss out even those 5% positive case, which would have been missed had we not done Sentinel. So it's rather than leaving or doing complete dissection and causing morbidity, it's best to do Sentinel node, which gives a better yield compared to the complete lymphadenectomy.
So another question arises, like we are trying to avoid the complications of lymphadenectomy. Does it compromise the survival benefit?
No, it gives a better survival because we are diagnosing better. We are as I said, 18 to 20% cases are upstage, which would have been lymphadenectomy detects a lower rate because the pathologist doesn't take so thin sections. You can't do immunohistochemistry for all the nodes. It turns out to be very expensive. So rather than that, spending time on one or two lymph nodes on each side, you can get better results. So you'll have better survival rather than having a low detection rate.
So, ma'am, in your institute,
on chemotherapy or if required radiotherapy. Now, chemotherapy is the first thing in management.
So, in your institution, how much time does it take to get the report? If you send the Sentinel.
I think Dr. Kanika was moderating my session when I operated live in a workshop. And I think she would vouch for it, 10 minutes on each side extra. It was just like a normal hysterectomy for the patient. So, and you can discharge in 2 days.
So that's for a frozen section. And now this concept of ultra staging. And what is ultra staging and does it improve the detection rate?
Yeah. Very, very relevant question because people have confusion about this. The frozen section is done only if you are doing sentinel nodes for cervical cancer, because there if the lymph node is positive, you stop the surgery. No point doing it, you send the patient for radiotherapy. But in endometrial cancer, the lymphadenectomy is not therapeutic. It is only to diagnose the stage. So here we do not send the lymph node for frozen section at all. Because if we send it for frozen section, then our final pathology will suffer. So our diagnosis will come down. So no frozen section for this, because basically we want to know whether this patient needs chemotherapy or not. So we do sentinel node, send it for permanent section, we do hysterectomy, and we wait for the ultra staging. So ultra staging is basically consists of two things. One is staining with immunohistochemistry, a stain for cytokeratin 19, and the second is after staining we take very thin sections. So it is the ultra staging which is most important thing in sentinel node. which upgrades our results compared to complete lymphadenectomy. I think unless we understand ultra staging, just doing sentinel node dissection doesn't help. Very
Serve the purpose, yeah. So next question comes, ma'am, you said low risk cases, yes, one should do it. So what about high risk endometrial carcinoma patients like grade 3 and serous, other varieties?
Very, very, very correct. Because, about 4% of the cases in these high risk cases may have the sentinel node in para-aortic area. So again, there are studies which say if you see in a para-aortic area, that will be an echelon node. Maybe you miss the sentinel node in the pelvis. So the FIRES trial is saying that even for high-risk cases, you can do a sentinel node. But because some people do not want to take risk, they want to do a complete lymphadenectomy in the para-aortic area also not. The thing is not yet established, but maybe in future it will be established even for a high-risk cancer.
Once we have more data, maybe in high-risk cases also, because it's overdone in 80% of the cases.
And in stage 4, maybe because we want to do debulking of the large lymph nodes also. So that's where there it is part of the debulking.
So there's a term used as failed mapping. What is failed mapping and the conditions where it is likely to occur? So what is it?
Right. We've injected the dye intracervically, and I see the fluorescence on one side, but on the other side, I don't see any fluorescence, any sentinel node. So that is failed mapping. So it can be either due to wrong technique of injection of ICT dye, or second, it can be the tumor cells obstructing a lymphatic channel. So now what to do? Because we've already done what should be done. So in that case, we can't take a chance, and it's best to do complete lymphadenectomy on that side and send it.
So why
That's
does it
very
occur?
important.
What are the conditions where it is likely to occur? Or it's just a technical thing?
No, the tumor cells may obstruct the main lymphatics. So that's why it becomes more important to do complete lymphadenectomy and not leave the case as it is.
Thanks, ma'am. That was a wonderful video, and thanks for clearing the concept of
You prepared the question so well. I must admire. You completed the topic. Thank you.
Very well taken. Actually, Dr. Indu was leading the questions very well, and the answers were coming so spontaneous. Very nice. Thank you, ma'am.
Thanks for clearing the doubts. I'm sure people, I think somebody has put the remark that video finished too fast. They wanted perhaps to see the video. So maybe we can share the videos.
Yeah. Thanks for the opportunity.
I think next we move on to another stalwart, Dr. Rama Joshi, who's a well-known robotic surgeon, and she's got unparalleled skills in doing oncosurgery. All of us know it. And lymphadenectomy, of course, we have to do in CA cervix and endometrial CA. So I would like to invite Dr. Rama Joshi for the expert opinion and the videos. Dr. Rama Joshi, yeah, good evening, ma'am.
Yeah, very good evening, Dr. Kanika. And actually, at the outset, I would like to really thank you for the kind invitation. And I was just listening to the wonderful conversation, whatever the way the questions and the answers and the way the Dr. Dinesh really presented the sentinel lymph nodes. So the topic given to me is, I think you had given me for the video that was, am I right, of the pelvic lymph node dissection. But definitely we can take on the discussion whichever the way you feel. All right, I have no problem.
We can have a video first and then maybe the question.
Sure.
Robot-assisted pelvic lymphadenectomy. With the retroperitoneal approach, the ureters were identified and dissected of the common iliac vessels. And here you can see the node which is lying right at the bifurcation of the iliac vessels.
The external iliac node dissection was started from the cranial to the caudal end. The genital femoral nerve was identified and also the psoas muscle. The fibrofatty lymphatic tissue was excised from all around the iliac vessels, preserving the genitofemoral nerve, and the dissection is carried to its distal boundary, where the deep circumflex iliac vein crosses the external iliac artery. Further dissection is carried from caudal to cranial end by excising all the nodes surrounding the external iliac vessels. The dissection was carried in the obturator fossa, and the obturator nerve was delineated with the medial approach. All fibrofatty lymphatic tissue of the obturator group of the nodes is dissected from its lateral pelvic wall, as well as from the obturator nerve and the surrounding areas with sharp dissection, and the nodal tissues are completely removed, including the node at the bifurcation of the iliac vein. These are put into the bag and clipped to be retrieved later. You can see the ureter. Internal iliac artery continuing as superior vesicle. This is the obturator nerve, obturator artery. Deep circumflex iliac vein, external iliac artery. Genitofemoral nerve. Psoas muscle. Lateral pelvic wall. This is the pelvic vein. Excised gland of Cloquet and completely empty obturator fossa. This is the pelvic anatomy after the completion of the pelvic lymph node dissection.
So, ma'am, that was a wonderful video. Even for persons who don't understand anything, I think they can learn anatomy if nothing else. That was a wonderful video. So, few questions. Does robot have advantage in doing lymphadenectomy over traditional laparoscopy? Do we have some advantages if we are doing the lymphadenectomy by robotic technique?
See, I just want to tell you the basic here. This has been the question which has been rather being discussed number of times, and this is what the way we are looking at. The first of all, it is the surgery which is important, and especially if it is the oncosurgery, that means what gynae oncosurgery, whatever we are doing, we have to follow the principles, we have to follow the guidelines. So we have to be very clear about the principles of the gynae oncosurgery, be it open, be it laparoscopy, be it robotic. So these are the technologies, and the technologies, I share my experience with you right from the beginning. When we were the students, we used to listen about the laparoscopic surgery, and our head of the department used to say that, oh, why to enter through Zarokha? Why not to open the door, do the surgery, stitch it back? But see, where are we today? I think we are all opting for the quality of the life of the patients, right? And going for the minimal access surgery, but of course, without any compromise so far as the outcome is concerned. So in gynec oncology, we are concerned about the outcome of the surgery. We are not just looking at, you can say, the...
Ma'am, we lost the connection. Shivam, have we lost the connection with Dr. Rama?
I think this says host is not allowing. Host is not allowing to enter. This is what.
Shivam, please look after that.
The host is not allowing participant to unmute. I don't know what's coming. Okay. So actually, there are studies which have looked into and compared the results of the lymphadenectomy with that of the robotic as well as the laparoscopy. And so far as the perioperative outcome is concerned, this was far superior with that of the robotic surgery rather than that of the laparoscopic surgery. As the surgeon, naturally, the precision, the number of nodes retrieved, and also the blood loss, I think, again and again, I'm having the problem. I don't know why this problem is happening.
And we can hear you.
We can still hear you.
Yeah. So actually, it depends on whatever the data they suggest that robotic is comparatively better in terms of the perioperative outcome than that of the laparoscopic surgery. Robotic has got superiority, especially in identifying the sentinel node, as you must have seen Dr. Dinesh Kansal was mentioning about. Mainly because the sentinel nodes, you will find in about 4 to 8% of the cases in the areas which are literally difficult. You have to go into the presacral space. And also you have to follow the lighted up area. Usually you will be assisted by the firefly mode of the robot. Whatever the intuitive we have, that is the Da Vinci system, has got the firefly mode. And this is very easy. And you can follow it to that of even to the para-aortic region. Once you go to the para-aortic region, you know this is where the sentinel node is. So identification of sentinel node is far easy. And of course, it depends from, you can say, the experience of the person. So we can't say that if I'm doing the first sentinel node, I'm doing the correct thing. So it depends from center to center to have their own experience of identifying the sentinel node. In how many percentage of the cases one is going to identify the sentinel node, compare it with that of the pelvic lymphadenectomy or periaortic, depending upon whatever is the indication for the lymphadenectomy for that particular case. Then we can say that fine, we are good enough, we have done 100 cases, and now our rate of detection of the sentinel lymph node is quite, I think, quite encouraging to that of 98%. And we are going to have the accuracy, and we can just take up the sentinel lymph node and we can leave the lymph node dissection in those particular cases.
So ma'am, as I understand, are you doing sentinel in all cases, or pre-operatively on imaging you can decide like in certain cases you will do lymphadenectomy straight away?
It's a very, very important question you have asked. Yeah. We are always following the sentinel node algorithm based on the NCCN guidelines. If we have got any patient, whether it is the low grade or intermediate risk or high risk, whatever, and we find that the lymph nodes are enlarged and suspicious, we don't go for the sentinel lymph node dissection in these cases. It is done only in cases where no suspicious nodes are there or no enlarged suspicious nodes are there. Then only we take up the patients for the sentinel lymph nodes.
Another question, ma'am, if indocyanine is not available, do we have some alternatives? Like
no,
one is of course
available. Indocyanine green is available.
Easily
what you require is a firefly. Firefly camera, even if I mean to say, this is what is with the advantage of the robot. Da Vinci robot I'm aware of. I don't know about the other robots, but I'm sure it is very much there, because if this technology doesn't have the firefly mode, I don't think so that this is to be considered as one of the basic concepts in the technology. It is even coming even into the laparoscopic surgery also. You can have the firefly camera.
Next, I come to a very controversial question, you know.
Yes.
About the role of minimal invasive surgery in CA cervix. You know, we all know, like,
yes,
we have so many cases of CA cervix, and early stages we can do, especially for young patients, we can do surgery. And over last decades, I think many of us, you know, started shifting to minimal invasive surgery until in 2018, you know, the results of LACC trial were revealed that minimal invasive surgery, overall survival is less and progression-free survival is also less. And then came the recommendations from NCCN and FIGO that it should be abdominal radical hysterectomy and not. So after this, where do we stand? You know, I mean.
Okay. Yeah. I think it's a science is, you know, that it is it is a continuous mode of learning. We do the things, we adopt the technologies, we assess ourselves, and then we say that this is where we stand today. So I think the same thing has happened with in the LACC trial also. And this significantly low survival rates in the patients who had been opted for, rather, who underwent the minimal access, minimal invasive surgery of laparoscopy as well as the robotic surgery, they had much inferior survival. Their loco-regional relapse rate was significantly high. And also the carcinomatosis, which was one of the another, you can say, the tumor spread was seen within the peritoneal cavity of all the patients of those who were failing it. So actually in oncology, this is what I say, that not the surgery doing today matters, but what matters is the 5-year survival. So if we can understand the 5-year survival, and of course, giving the best to these patients who are already compromising with the life, how to give them the best so far as the survival as well as quality of life is concerned, is the real concern for the gynec onco cases, and not the technology. Unless we have the other, you can say, the trial which is coming into LACC is a randomized trial. We have to accept the data. We can't just say that there is some or the other kind of technological problems. And the final, actually, you can say, the final results were recently presented in IGCS. That was in SGO conference recently. Pedro only had presented the results, and it was much inferior than what we were otherwise thinking. So basically, these are the concepts, and also the learning out of the randomized trial. We really cannot ignore it. But what is thought, and the one point which was narrated this time was that those patients who had very early cervical cancer and had conization, after that, when these patients had gone for the minimal access surgery, comparatively, the recurrence rate and also the death rate was comparatively less. But I think we are waiting for the final results still. There had been soccer trial, which was a retrospective trial and was also looking into why did we fail in the minimal invasive surgery. And in that trial, they tried to establish that whenever we are actually closing the cuff of the vagina before any kind of the manipulation, that really makes a difference in recurrence rate. This lowers the recurrence rate, but this trial has not been given that importance because it is simply a retrospective trial. So today we stand as, so far as the oncological principles are concerned, in cervical cancer, I think there is no place for the minimal invasive surgery.
But there are certain criticism to LACC trial, like 85% of the cases were done by laparoscopically, and there was no sub-analysis. Like even tumors more than 2 centimeters were included, and they didn't do a subgroup analysis.
See, I agree with you that so far as the distribution of the cases of minimal invasive, this is what I said, minimal invasive, there have been studies which have compared robotic surgery with that of the open surgery. And they have shown the results are not significantly different, but these are not that kind of the randomized trials. I think we require to have the proper randomized trial, which is going to answer this question, whether laparoscopy, whether robotic surgery, or open surgery.
So one point, ma'am, you made that vault closure should be done before we do the completion. Any other precautions one should take to avoid tumor spillage if one is doing?
See, I personally would like to make one comment here. Whether it is endometrial cancer or it is cervical cancer, I'm talking to you about, say, endometrial cancer.
Yes.
There is no role of intrauterine manipulator.
Yes.
Because that is definitely the reason for spillage of the cancer cells. And we really don't know how to do it. So always we go for the vaginal manipulation. We have never used the intrauterine manipulator, except in our initial cases where it was rather felt that using the simple VCare into the endocervix will not cause any problem, but I disagree with it. And it is the simple vaginal manipulation which will really help you and give you good results in the endometrial cancer with the minimal invasive surgery.
So thanks, ma'am, for making the whole concept crystal clear and where do we stand. So, and we'll wait for the results. But yes, if we select the cases, maybe in future, like low risk cases and less than 2 centimeter, grade 1, grade 2. Maybe, you know, it still have a role. You know. So,
we are sure we all are looking into what are we looking at is the quality of life as well as the survival. So I think let's wait. But till then, whatever the lesion, if you are seeing grossly on the cervix, makes 1B1, be very, very careful. It is important that we have to give counsel the patient well, that with the minimal invasive surgery, this is what is the chances of the likely chances of the reduction of the survival as well as the recurrence, increased chance of the recurrence. This is very, very important.
Thank you, ma'am. So any input, Dr. Kansal, regarding LACC trial?
I'm not a oncosurgeon as such.
Yeah.
So I think Dr. Rama Joshi is the final verdict.
Yeah.
But we all understood, Dr. Dinesh, and I think we all understood that this is where we stand. And so we have all changed our practice, isn't it?
Yeah. I think endometrial cancers we can do, but cervical cancer is not my field. That should be done by Dr. Rama Joshi.
So from oncology, thanks, ma'am. Thanks, Dr. Rama. Thanks, Dr. Dinesh.
Thank you so much.
Yeah.
Thank you so much.
So from oncology, we move on to another field, to a non-gynecological field, that is VVF. We have enough evidence that robot-assisted VVF repair is feasible, gives good results, and does provide advantage over conventional laparoscopic or open. So now I would request Dr. Vipin Tyagi, who is a senior urologist in Sir Gangaram Hospital, to share his experience. So over to you, sir, Dr. Vipin Tyagi.
First of all, thanks to Dr. Kanika, Dr. Endu, and Dr. Swati for inviting me as I should say, a special person, because I'm not a gynecologist, but I today learned many things about gynecology, the lymph node dissections and the sentinel lymph nodes and firefly techniques, which we also used to use. So it is something which is more generalized. And before coming on to the topic of exactly on the vesicovaginal fistula, few points, being a robotic surgeon, I want to emphasize, which I gathered by listening about 1.5 hours of this things starting from Dr. Chaube. So the first point is regarding the Versia system, the CMR and the intuitive. So I have used both the system. Last weekend I was in Goa to have an experience of CMR, and it is a very good system, but it is not intuitive. So intuitive is more like a Mercedes and BMW, and CMR is more like an Audi or a finer version of Hyundai or Maruti, but it's not as good as intuitive. And there are certain pitfalls which still need to be covered by CMR system. It is still not FDA approved, but yes, it has its own place in the market. The second point which I want to make, that during those lymph node dissection, which is the primary part of concern in any oncological surgeries, pelvic oncological surgeries, that when we are doing the lymph node dissection with robot, we have to understand that we are dissecting around the vessels. So if in case we accidentally do some harm to the vessels, it is very easy to suture those vessels if we have a robotic instrument in my hand. That freedom of the range of movement give me a surety that if something happen, I can just repair that thing. Otherwise, the morbidity of these vascular complications can surely convert into a mortality. And now regarding the VVF, can I ask Shivam to play my video?
Yes, we'll have
sorry for the quality of the video. This was the case which was done, I think, about 9 years back. and one of my first vesicovaginal fistula repaired. And this patient comes to me with the history of hysterectomy, followed by the pervaginal leak. We do a cystoscopy, and we found 3 fistulas. And because it was the initial period of my robotic experience, I was honestly a little apprehensive using the new technique in a patient who has a complex fistula by virtue of the numbers. So to make my surgery much more safer, I started putting uretery catheter into the ureters in initial of my vesicovaginal fistula. Now I only put once it is required and once I feel that I need the fistula is very close to the ureters. In initial courses, I have used 5-port techniques and 3-arm technique, but now I use just 2 arms for the fistula repair. And let me caution all of you, while we're doing a laparoscopic or a robotic or any minimal invasive vesicovaginal fistula repair by the transperitoneal approach, the most difficult part I have found is the adhesions, because something bad has happened during the hysterectomy. That is the reason of making these fistulas. There is a lot of inflammation. The bowel, the mesentery goes and stuck to the bladder and the vagina. So we have to be very careful before approaching the main field of interest. And the principles of fistula repairs are same. We make a plane between the vagina and the bladder. I have also did the laparoscopic VVF repairs. The main advantage of the robot in the vesicovaginal fistula repair is A, dissecting between the bladder and the vagina, because now we can move like our hand deep in between the bladder and the vagina. And B, the suturing of the vagina, because vagina needs to be closed horizontally. So every suture has to be perpendicular to the vaginal mucosa. And by virtue of the robotic instruments and their versatility, we are able to achieve that. And once we do the proper vaginal closure, we can we always mobilize the omentum, put in between the bladder and the vagina, and then close the bladder. There are the few cases where we are not able to find the omentum. So I have used fibrin glue, that is Tissil or Avicils, so as to just seal up the repaired vagina and the bladder. And in one of the case, we are not able to have anything available to us. So in that case, we have not put any interposition tissue. In my experience of more than 30 vesicovaginal fistula repair, we have one failure. That patient have a bad fistula, which is involving going up to the bladder neck and the right side of the ureter. In another patient who has also the involvement of the left ureter. In first patient, we are not able to salvage the fistula because the patient is very elderly, very frail. So we have never attempted the second repair. But in the second patient in which we failed, we again did the robotic vesicovaginal fistula repair. And now that patient is doing good without any leak. So many of the urologists also says that, yes, I can do this surgery with the laparoscopic suturing skills, but it's not what we can do. It is always what we should do. And we should offer these patients the best technique available. These patients are patients who have this disease coming to them as a complication of a procedure. So whatever treatment we are offering them should be giving at least maximum success rate as compared to the prevailing techniques of open and lab. So this is the end of the video, and I'm ready to answer any questions, any queries, any suggestions.
Sir, we as gynecologists, we repair most of the obstetric fistulas by vaginal route. Even post-hysterectomy fistulas, the success rate with Let's Go is very good, So what, in your opinion, are the cases which are ideally suited for robot like?
Right. So first of all, in my experience, I'm also surprised. Most of my fistulas are gynecological fistulas, which are done during the hysterectomies. I have seen few fistulas which are obstetric fistulas, and I'm totally agreed. the transvaginal is a very good technique to repair these fistulas. But these type of fistula which are done after hysterectomy, these laparoscopic or abdominal approach, whether it is open lap or robot, do provide a very good access to the fistula A, and do also provide a good interposition omental graft.
Yeah, that's...
And I always believe that putting a very good graft between the repaired vagina or a repaired bladder provide a better success. But yes, I'm not a gynecologist. I'm not good with the transvaginal approach. So for me, every fistula, I can repair it with a robotic technique. But yes, if there is a fistula which is lying down below the orifice or subtrigonal, I will always ask my gynecological colleagues to come and repair that fistula. But honestly, I have not seen any fistula which is below the trigon.
Gynecological fistulas are usually higher up.
Yeah.
Obstetric fistulas are at the base, at the trigon.
And for me, I've seen more gynecological fistula rather than obs fistulas.
Actually, Let's Go is ideally suited for very small fistulas. If you have large fistulas, it's not done by vaginal route. So, sir, in my OPD experience, one fistula which nobody wants to touch is our patients of CA cervix who have received radiotherapy. So, can they be done by minimal invasive technique, by robotic?
So if I can remember correctly, the patient, the elderly female I'm talking about, whose fistulas we failed, is a post-CA cervix. I hope that therapy. And in that particular patient, it is a hell of a job to do this business. Yes, we can attempt, but I always be in favor of doing a transvaginal approach rather than a trans-abdominal approach in these type of cases.
Okay. So any situation where robotics should be avoided?
I think robotic is, I think I always make a point. Look, robotic is not a technique. Robot is an instrument.
Yes.
So like we use a harmonic, like we use ligashore, like we use a Hemolock applicator. It's not a technique, it is an instrument. So you have to optimize and justify that these are the indication for using my robotic technique, right? Say for example, why I use a robot in vesicovaginal fistula, because it mandates a good suturing, a suturing which is not very much possible by a laparoscopic way, and a dissection between the vagina and the bladder. The same way in radical prostate, taking out a prostate is not a big deal. It is the vesico-urethral anastomosis. I do a lot of radical cystectomies in which I do all the diversion by intracorporeal way. In that, the intracorporeal diversion is done by the robot. So a robot is an instrument and you have to justify its use. So for me, the main contraindication is if something which you can do by laparoscopic way, why to dock a robot? Why to increase the cost of the surgery? Just for the sake of using a robot, robots should not be used. Otherwise, any contraindication of laparoscopic surgery is a contraindication of robotic surgery, because it is an extension of a laparoscopic surgery. So I always believe use an optimized use of robot and justified use of robot, not an excessive use of robot.
So thank you very much, Dr. Vipin. So we now go over to the next panelist, and I hand over to Dr. Kanika.
So we have learned a lot about the robotic assisted laparoscopic surgeries. We've seen all the pluses, and mainly the pluses, few minus. None of the, I guess, am I audible?
Ma'am, you need to come closer to the mic, ma'am.
Okay. So what I was saying was that we've learned a lot about the robotic surgeries and robotic assisted, and the advantages and certain disadvantages. But no procedure is without complications. So we have an expert here, Dr. Anupma Bahadur from AIMS Rishikesh. She would be highlighting and telling us about the complications which are possible and how to avoid and manage them. So Dr. Anupma, we know she is a pioneer in robotic surgery in AIMS Rishikesh. She started with the robo there, and I would like to know what could be the possible complications vis-a-vis the robo as compared to laparoscopy.
Good evening, Dr. Indu and Dr. Kanika. Dr. Kanika has been my senior resident when I was doing my DNB in Gangaram, and it's really good to see you and of course Dr. Swati. Hi, Dr. Mala. Yeah, Dr. Harsh, it just feels like home to me. So yes, what are the complications? So when I started my journey, I would say the very first case I had a bowel injury with the tenaculum. So if you can play the video, we used the third arm and we took a tenaculum in that. And as soon as the doors opened, it caught the gut. But by the time we detected it, the tenaculum had already moved away from the field of vision. So it wasn't, it was instantaneously that we picked up the injury and
Shiva, could you put the video?
There are hurdles that I've faced in my journey so far, and that is what we are here to witness and learn from. A sudden bleeder in the field can shake off any calm surgeon's hands. In my case, when the vision got bloody, I first decided to clear the visual field, calmly went back in, caught hold of the bleeder with fenestrated bipolar and cauterized it. Once I had secured the bleeder, complication for the day was well corrected. Then came the next gloomy day when the bladder started weeping. I did a 2-layer repair with Triovicryl to seal the leaking bladder. This was a patient with previous 2 cesarean sections, and in such cases, it is always wise to call for help. Our urology colleague stepped in and used the epiploic appendix to seal the bladder further. With the leak gone and bladder looking watertight again, I was assured of yet another complication well managed. Tenaculum, an instrument used to stabilize the uterus. But in our case, the tenaculum decided to play difficult and cause havoc in our robotic paradise. It opened its jaws like a shark and floated away out of my visual field. I quickly explored the bowel loops and with a keen eye found the gut injury the tenaculum had left behind as a serosal tear. This was sutured with Vicryl Trio, and there was no post-operative complication faced by the patient as well as our team. The next hurdle was genuinely unexpected, wherein the manipulator, a usually silent instrument, decided to let go of its grip on the uterus, its sharp jaws threatening injury to both bladder and bowel. Thanks to my efficient team member, our assistant manipulated her way through and prevented both bladder and bowel injury. I once landed in a soup with the vault closed and bilateral salpingo oophorectomy pending. I completed the procedure on both sides, but didn't realize that recovering the specimen would pose a problem. Both tubes and ovaries were placed in the endobag, and while the endobag was being retrieved, in a tug of war, the endobag suddenly gave way, and then our search began for the 2 lost ovaries in the pelvis. They were eventually found, bisected, and retrieved. The manipulator works efficiently undercover, but in our case, it decided to give a sneak peek coming through the uterus. We shut it back in its cover and successfully withdrew and reinserted the manipulator. There is no charm without challenges. What else would drive us further? And as they say, productivity and limitations go hand in hand. This was Da Vinci for you.
Thanks, Anu. Excellent video. So, do you think the incidence of complications in robotics is higher as compared to the laparoscopic surgery?
See, if you look at literature, there's recently been a paper last year, and they've compared open surgery vis-a-vis robotic and laparoscopy. So the incidence of complication more or less is the same. There is no statistically significant difference. It all depends on the volume of cases that you're dealing with. So in robotics, the higher the volume, the lesser the complications. So once you have attained your learning curve, you've mastered your learning curve, and you already a trained laparoscopic or an open surgeon. So I also moved from open surgery to robotic. Without, of course, in Gangaram, I was with Dr. Kanika, we used to assist Dr. Marwa a lot in the TLH that he was doing. But after coming here, it was open to robotics. So once you very well know the complications that you will be dealing with in open or laparoscopic surgeries, you're always very careful as a surgeon. You work with that principle of do no harm to the patient. So you're always careful. So having said that, as a surgeon, you are bound to face complications, and if you do, you know how to handle them. So whether being in a tertiary care institute, suppose we had a bladder injury, that was again our first few cases where we had a previous 2 cesarean. So I thought it best that I should call a urologist, since the urology team is also very well trained in robotics in our institute. So with their help, we managed to repair it and we managed to come out. So with help at hand and always learning from your experience, learning from your complications, you move one step to another. So that is what I would like to say. But complications, of course, even a simple trocar when you put in, I've even injured the inferior epigastric once while putting in a trocar, and in that case there was immediately, the patient was going into shock, and the anesthetist told us, please open and move, and then only proceed. So we had to immediately rush for blood and opened her up, did a laparotomy. So complication can occur at any and every step. It can even occur.
Are there any complications which are specific to the robotic surgery?
In robotics, I would say it is, when you are actually docking and when you are, what do you call it? Due to the robotic malfunction, it can occur. So robotic malfunction can occur something between 0.4 to 4%. And you have the arms colliding with each other. Those are the complications that you face initially in your journey in robotics. So one has to deal with that, and that comes with practice. With practice, you overcome those kind of complications.
Definitely, and I mean, very nice videos shared, Anu. I'm really proud of you. You've reached heights, and it's amazing. That's really nice, and I think, as you said, the learning curve has to be there for everyone, with every modality, with every route, and it has a comparatively shorter learning curve as compared to laparoscopy. And if facilities available, if you have the robot available in the institute, I think one can go for it. So thank you so much, and I thank all the panelists. It was really nice being with you, nice discussions. And over to Swati again for the conclusion.
Thank you, ma'am. So after this very stimulating and enriching panel discussion, I think a round of thanks is in order. So it's my proud privilege to deliver the vote of thanks for this evening. And I would like to take this opportunity to express my thanks to all the esteemed faculty members who have taken out their precious time to enrich us with their wisdom. And first and foremost, I would like to thank our guest of honor, Dr. Malvika, who has always been our guiding light. I thank my core team, Dr. Mala, Dr. Kanika, Dr. Indu, who have shaped this event and given it its final form. I thank the chairpersons, Dr. Gujral, Dr. Harsha, and Dr. Mamta. And of course, the star speaker of the day, who's not, I think, in the meeting currently, but Dr. Dubey, Dr. Chaube, sorry, who has shared his journey and inspired many of us today. I also wish to convey my heartfelt thanks to the wonderful panelists for their wonderful videos and their excellent answers. I think the panel discussion was the cherry on the cake. It was so good, and the time just flies. You know, Dr. Vandana, Dr. Mala, Dr. Dinesh, Dr. Rama, Dr. Vipin, Dr. Anupma, your videos were just excellent videos. And I also thank Conferences International for the technical support and Intuitive Surgicals for sponsoring this event. And last but not the least, I thank the wonderful audience for staying with us and making this event a huge success. So with this, I would like to bid adieu to all of you. Good night and Shubh Ratri. Thank you.
Thank you so much.